Are you sleepy? Yes? No? Rib burn. You shake your head like this. This is yes, right? Okay, just make some stretching. Okay, I always sleepy. Okay, let's start with the modified stopper. Because they give me only 12 minutes, I think stopper is the one that really more useful for us than the Pararectus. Yeah. What is the stopper approach? The advantage? Anatomy, the surgical at risk. And I just show you 2 cases. That should be enough. But I emphasize on the structure yet you cannot see it, but it's there. Yeah, we know the AIP or the anterior intrapelvic approach is originated for the hernia surgery. It's not for us. And then we modify to approach this inner surface of the pelvis. Yeah, it's the expand. You have to do the surgery from the opposite side, yeah, and you go to see the opposite pelvis cavity. You avoid the middle window. Yeah, many of you may say, okay, Professor Lahat loves the ilioinguinal approach. He always make a long one. Yeah, for me, yeah, it's good, but I'm lazy because I need 1 hour to do the sutures of this inguinal ligament. Yeah, but for the stopper and the lateral window, if you combine it, it's faster. Yeah, and it's smaller incision. You have no risk of the LFCN injury if you compare to the ilioinguinal approach. You can see directly quadrilateral surface from this view. But if you go ilioinguinal, you come from the top. You can see the top, you can put the screw from the top, and you can feel the inner surface. Okay? Contraindication. Yes, it's clear. The posterior fracture, you cannot see it, like Ajahn Vanchak already tell you. Bladder surgeries maybe increase the risk of the infection if you have the colostomy, cystostomy around that area. History of Caesarean section, hysterectomy. I make a question mark, maybe or maybe not. It depends. Yeah, if there's already funnel steer approach for the Caesarean section, I think that's maybe the problems. Yeah, but I try few cases of mine that I need to remove the screw from this approach. It's possible, but you be very careful to remove, to get in again. Okay, look at this intrapelvic. You see the red area here, right? This is area. You can see from the Stoppa approach. But if you want to see the iliac wing, it's not possible. So we can combine the lateral window and the intrapelvic approach. That means you make 2 incisions, not the long ilioinguinal. You see this is classic ilioinguinal approach. From here down, yeah, we just make in the middle. We don't want to dissect this area. Okay, we make a funnel still. Everybody knows how to do it. Yeah, symphysis fixation is easy. The key is when you make a dissection, going up is more important. Yeah, lateral dissection is not that so important because you have to work in between the rectus. Yeah, so spread it up very high, and then you have more space to work. Another trick, when you go down, you start first down there at the retropubic space. You find the space, and then just make a cut on the back of the rectus. You don't cut on the front because the rectus is go anterior and posterior, just the posterior part, and then you have more space to work. Okay? Yeah, this is the additional lateral window. Now, after you go in, you find the symphysis. You have to walk around the brim. Yeah? Carefully dissection with your fingers. I always use my fingers or use some soft dissection around 6 to 8 centimeters from the symphysis. There should be a vessel there, a small one. But if it's bleed a lot. That's the corona mortis. Yeah? Trying to find it. I think 80% of the case you will find it. There's artery and the vein together. You have to look for it. And sometimes there is some adipose tissue or fat that's covered. Yeah? You just try to clean it. Okay, this is the corona. Oh, it's not so clear. Yeah, this is the obturator, and this is the corona. Okay, I will go further that you can see more. Okay, the Homan application and the Deaver retractor. This is important. If you know how to put the retractors, your view is really clear. Yeah. Nobody can retract this pelvic surgery or acetabular surgery for 1 hour, except you have a good instrument. Yeah. This area, we have 3 Homan. I will show you later. But at the iliac fossa, this is the external iliac vein. Don't use any sharp retractors at this area and flex the hip to release the tension. I think few of you have experienced that you tear the external iliac vein. It's terrible, right, with this approach. Yeah, in this picture, they show you that this is from Saki, 2010. Yeah, he used these Deaver retractors to clear this obturator artery and the nerve down, and you can expose. But usually, we don't want to see much like this. Just above half of this is okay, right? Yeah, you can reduce these fractures, the posterior column, by this approach, but you have to have these special clamps. It's not the normal one. It's special shape that you have to go in, yeah, like another one. But this one, you have a very good instrument that you can go down to the ischium, and you need the light. That's from the striker. Yeah, it's very expensive, but if you have money, it's very helpful. Okay. Yeah, you can plate like this, or you can put the rim plate, and you push screw from front to back, yeah, anterior to posterior, but you need another window on the top to fire the screw down. Okay, we published this article. You can go 2019. We only see what we know, the structure at least with this Stoppa approach. Okay, let's see, 3 retractors. This from the striker manual. The first retractor is the one you put at the pubic tubercle. Remember, pelvic tubercle. The second one, anterior acetabulum, at the iliopectineal eminence. And the third one, this is the lateral of the ilium, lateral to the SI joint. Then you can expose the whole area of this bone. Now, I show you these pictures. It's from the cadaver, but you can see it if you put the correctly of the retractors. Now, this is the infrapectineal plate. You can see the supra here, and this plate going down. Okay, look first. This is the marker. SI joint is here, right? Don't go medial to the SI joint. There's an artery. There's a vein. Yeah, this is the first. The third retractor is here, right? Lateral to the SI joint. And this is the second Homan, anterior acetabular rim. And this is the pubic tubercle. From this approach, you will see all this pelvic rim. Corona, now is very clear. Yeah, I make an injection. Tomorrow, we're trying to show you. After this lecture, I will go to the lab and I try to inject the dye into the pelvis. Maybe it's work, I hope. And you will see like this. This is the obturator artery. Nerve is here. And you see the connection. This is the artery going up. This is a coronary artery. And this is the vein. Okay? It's connected with the external iliac. Okay? Be careful. Sometimes you are, oh, I find it. I like it. I clip it already. Yes? And then I make a sharp knife dissection. There's sometimes it's another one. Be careful. There's a 2 artery, 2 corona. It's possible. So let's see, going really clear until you see the whole brim, and then just start cutting the iliopectineal fascia. Yeah, external iliac vein is here. Yeah, you cannot see it well, but it's there, under your retractors. Now, this is all the structures. Dangerous, huh? Iliac artery, iliac vein. But normally, we work around this area. We don't go medial to the SI joint. Yeah, that's dangerous. Yeah, and this is the iliopectineal fascia. That's here. When you want to cut it, you see all this, you like get the corona, and then you cut all this on the brim. You have to see by your eyes. Yeah, and then you expose on the brim. Yeah, and this is the Homan. The second one that you leave it at the iliopectineal eminence. And the third one should be here. And then you see all this pelvic brim. Okay? Is clear? Okay. This is the one you don't want to see it, but it's there. Yeah? This is the common iliac artery. And this is the external iliac artery, external iliac vein. Yeah, it's just under the retractor here. You flex the knee, flex the hip, you relax the iliopsoas and the soft tissue around here, and then you use these retractors under the external iliac artery and vein. Okay, just show you a case. This is bilateral transverse fractures and symphysis. I did this case, I think it's more than 15 years now. It's a little bit difficult for me at that time. Yeah, this is my period planning. I sit, I make a bending of the plate, 2 on both sides, and 1 on the symphysis. Right now, the young, they do just the smiley plate, very long one. Yeah, it's so difficult for me. I just make a separate. Yeah, 1 incision. Going up, retropubic space. This is the fractures. Reduce it, and temporary fixation. Now I fix from the top. On the medial, I can make a plating, right? And I plate on the brim, inner surface. Yeah, you can plate on the top or on the inner surface. And this is a symphysis plating. And this done. Yeah, don't try the smiley plate if you are not experienced. It's not that easy. Okay? It's healed. Okay, another case. This is a combination. It's a both column fractures. Just to show you fastly. Yeah, it's. Yeah, you will see this in the anatomy lab. We can do the combined approach because we know we cannot go up here with the Stoppa approach, but we can reduce all this from the Stoppa. So we make a combined approach. Lateral window. Yeah, and we can fix. This is the lateral window, and this is the Stoppa window. The plate coming down here, going down, and this is the Stoppa approach. Right? So we have 2 windows. If you connect this, it's the ilioinguinal approach. Yeah, and then we can put the screws from the ilium and down to the symphysis. And the long screws from front to back, you see here? Yeah. Normally it's around 70, 80 of the screw that you can put it down. Yeah. Yeah, this is the incision, and this is post-op. And you see the clip, right? You have to see the clip. That means it's the corona. 6 months. And this is the function. Yeah. So the take-home message. When you start doing this Stoppa approach, you find the tubercle, then gentle dissection around the brim. Yeah? Clear the soft tissue from the brim. Avoid injury to the corona. Obturator, artery, and nerve, you must see it from this approach. If you want to go down, you have to detach some part of the obturator internus. Flexion of the hip, important. Yeah. So you have to drape this leg free when you do this approach. Carefully dissection iliopectineal fascia from the pelvic brim. Yeah. I make a line, markers, and then I feel it again, I'm sure. Because if you cut above this, you cut the external iliac vein. Right? So on the brim, always. Huh? Avoid dissection or the placement of instrument medial and lower of the SI joint. All the artery and vein are there. Thank you very much.